Okay, we're live. Welcome everyone to today's webinar on mental health in pulmonary arterial hypertension, PAH. My name is Robert. I'm a project manager with Admedicum, and I'll be moderating today's session. This is the 6th webinar in the series organized by the Alliance for PH, a nonprofit organization that is patient-led and promotes the exchange of knowledge and expertise all around PH and living with PH, and that's why we're doing this series of webinars. You can see the other ones on our website, as well as read the transcripts. And yeah, mental health, today's topic is a really important one because I think over the years we've made a lot of progress in managing PAH with new treatments and surgical options, which is what some of the other topics have been so far this year. But it's important to recognize that the emotional and psychological impact of the condition can be just as challenging as the physical symptoms. Mental health is a really key aspect of holistic care, and addressing it can significantly improve the overall well-being of patients living with PAH. And so that's why today we'll hear from some distinguished experts in the field. First off, Professor Karen Olsen, then Dr. Greg Rawlings from the University of Sheffield. And Professor Olsen is from Hanover Medical School. And we also have Sofia Esteves, who has come to share a personal journey and patient perspective about this important topic. So looking forward to an engaging and insightful discussion with you all. And please put your questions for our panelists in the chat box in wherever you are watching us. So with that, Professor Olsen, please go ahead.
Yes, thank you so much for the introduction. I'm very happy to be here, and I just want to send some thoughts to Sandeep Sahai, who wanted to be here, but sadly his son passed away and he couldn't lead the seminar with you. But I think we can only assume what he's going through, but not imagine. So. We will just start the seminar, but our thoughts are also with Sandeep. So I would like to share my screens, and this may take a little moment.
Yeah, thank you for mentioning that, Professor Olsen. That was, yeah.
So just shortly, my disclosures. I'm, as you said, I'm working at Hanover Medical School, and I'm doing a lot of diagnostics, invasive, non-invasive, and I often do the first diagnosis of pulmonary hypertension, pulmonary arterial hypertension. And I think when I do the echo, when I do the right heart cath, even when you see smiling faces, so this is me and a patient who has done a lot of cath. The diagnosis of pulmonary hypertension, like this means a lot. So if I meet the patient, probably he's gone through a lot of time of suffering, misdiagnosis. He's been told, well, just train some more, just lose some weight, and your dyspnea will get better. And there's a long way behind. And with the diagnosis, there comes, on the one hand, there comes certainty that there is something that you're not simulating. But on the other hand, I think within a minute, there comes a big burden on the patient. So you don't know, can I work? Can I have a family? Can I travel? Will I get old? And you have to deal with severe dyspnea, even like doing your groceries or just going to the metro station will be a big problem. So, and also there were a lot of studies where in the first years, I think in pulmonary hypertension, we just try to keep our patients alive. And then over the last years, I think we have had a lot of studies who told us that mental disorders are really or there's really a lot of mental disorders in patients with pulmonary hypertension, or they are severely mentally impaired after diagnosis. And then where our studies or our concentration on mental disorders began was um, in the kindergarten, because the girl you see right before riding the bobby car of my son was the daughter of our one of our psychiatrists. And I asked him, well, we need to do something. We need to take care of the patients. But like the typical psychiatrist, no, said no. We have to start even before that, because when you have a look at all the studies you're showing me, all those studies, they show like until half or up to 50% of the patients having depressions or anxiety disorders, but all of them they were done or performed with self-rating questionnaires, and not a clinical interview, which would be the gold standard. So we implemented the PEPA study. Well, at this time, it's clear where the name came from. Not only Peppa Pig, but in German, this means mental disorders and quality of life in patients with PAH. So this was published some years ago in Frontiers in Psychiatry. And I'll give you a short overview what we found out with this study. So the hypothesis was that PAH is a rare and life-threatening disease. There was so far no cure at this time. So the diagnosis is often delayed. It's a progressive disease, and the fear of the future, limitations in life and working capacity are definitely problems the patients are facing. And the development of a mental disorder should be obvious. And the existing studies, they all were based on self-rating questionnaires. And we wanted to have a large cohort. We wanted to do it prospective and multi-center, and with validated questionnaires and a structured clinical interview, which is the gold standard. So we worked together with the medical school and University of Gießen-Marburg. So together with Hanover, we had the two largest German PH centers, and we were able to enroll 217 patients. We implemented parameters of clinical routine. We had lifestyle questionnaires concerning sports, alcohol, relationships. We also had standardized psychologic questionnaires like the Hospital Anxiety and Depression Scale, the HADS, or the WHO Quality of Life BREF score. And we had, of course, the clinical interviews, which were performed by a psychiatrist or our well-trained student.
Sorry to interrupt, Professor Olson. I think in the end, we're looking at my screen because we weren't able to see yours. So I wonder if you can look into the StreamYard window and tell me next for the slide.
Okay.
I've been trying to follow along for the last minute.
So we have to go next.
Yeah. Okay.
And next. And next I have, okay. So this is where we are. So yeah, this is where we are now. Great, so the aims of our study were to see how is the prevalence of mental disorders. We compared it to the general population in the same age. And we wanted to see the impact on quality of life. And we wanted to see the diagnostic value of the HAD score to identify mental disorders in PAH. So next, please. Next. So as a result, we could see that mental disorders were significantly more prevalent in patients with PH. You can see on the left side, here's the normal population. And about 1/4 of the patients had a major depressive disorder. And also a lot of patients, 15%, had a panic disorder. And next, please. So more than 1/3 of the patients had at least one mental disorder, and there was like a higher prevalence of depression, 23% versus 8%, and especially panic disorder, 15% versus 2%. So 3 times or 8 times higher than in the normal population. So next, please. So here you can see it like in a graphic. Here are the mental disorders. In brown or orange is the general population. In blue there is PAH, and you can see that in almost all entities there's more in PAH as in the general population. Next, please. So what we also found out that about 38% or almost 40% had an adjustment disorder after diagnosis. And approximately 50% of the patient with an adjustment disorder were in risk to develop any other mental disorder if the adjustment disorder was present. So an adjustment disorder is a maladaptive response on a psychological stressor. So I think it's quite normal that you are under stress if you have such an impactful diagnosis and problems. But it depends on the response, if it is classified as disorder or just a normal reaction. Next, please. And well, it looks kind of complicated, but what this slide shows that the quality of life is lower in PH patients with mental disorders compared or in all domains, as you can see. And depression and panic disorder, especially you can especially here shown in this graphic. Next, please. So the question is, how can we detect mental disorders in our clinical routine? It would be very nice if all patients could undergo like a clinical interview and psychological evaluation, but as you all know, this is not realistic, because even if patients who have a problem, it's really hard to get psychotherapy or to get an appointment, because resources are really limited. So next, please. So we wanted to check if the HAT score, maybe as a simple diagnostical tool, could be used to identify patients who could need psychological support. And it showed good correlation, so it is maybe a good and fast detection tool. Next, please. So in conclusion, mental disorders are common in PAH, and they have a negative influence on quality of life. Mental health is an important part of PAH and should be paid attention to. The HAT score may be used as a screening tool, and the future studies, I think, need also to address interventional strategies targeting mental disorders in patients with PAH. And the access to psychological support is crucial. Okay, mache ich gleich. I'm sorry.
No problem.
Marius Hopper was supposed to be my babysitter, but he's still in the clinic. So next, please. I'll be ready in a few slides. I have brought you some additional slides, which are maybe some point of discussion for later on with Greg. I'm not a psychologist, but we tried to find a solution. We had a psychologist in our on our ward who was specialized in metacognitive therapy. So this is a little different to the usual cognitive behavioral therapy, and it addresses the metacognitions in patients. We also saw that metacognitions, which means like rumination and thinking about some things, are really different in our patients. So metacognitive therapy, we try to apply this in our patient, and it has the advantage that it's only a few sessions, and it might help patients to get over at least the pathological ruminations on their disease. Next, please. So this is oh, it's not really clear. So this is just an example from the patient, or one patient we treated. She was always thinking about her disease and checking and checking and checking. And with the metacognitive therapy, her thoughts were changed to, my body will tell me if it needs attention. So the theory is that there is a cognitive attention syndrome, which is characterized by inflexible attention, worry, and rumination. And the coping then is dysfunctional. And the metacognitive therapy will discover this with the patient and then give a solution or alternative ways to cover with it. Okay, next, please. And then I think another aspect which we could discuss later on is work on the mental health. We did a study, and just in short words, we saw that, of course, next slide, please. Oh, you can't see this. Yeah, okay. That there was a strong association between quality of life, education, and employment status, and the physical condition. Of course, patients who had a bad physical conditions weren't able to work. And the educational status, of course, goes in hand with physical work or just or mental work. And so, of course, physical work is much harder to remain or to achieve if you're physically impaired. And what we saw is that employed patients had a significant better quality of life. And if you go into detail, I think the best quality of life were in patients who had like a part-time job, enough time to take care of your health, but also be able to work and to contribute. Next slide, please. Next, please. So we then had a milestone in the last years or months, the development of sotatercept. And what we saw in clinic was that we had the feeling that patients, well, at first we thought, well, with sotatercept and everything get better, like mental health will get better anyway. But it didn't. We had so many contacts and so many other problems. And so we did the same, what we did before. We had 20 patients who had participated in the first trial and who had at least 6 months of sotatercept. And next slide, please. So the prevalence of mental disorder was comparable. There was no change in metacognitive beliefs. We had a higher prevalence of general anxiety disorder or adjustment disorder. And what we did see in question was, or in our questions was that sotatercept influences patient outlooks, hope, and lifestyle. It had multifaceted impact on both physical and psychosocial aspects. So many problems. Will I be able to keep social security? We had some patients whose partnerships ended because the partner finally said, well, I don't need to, you're well now, I don't need to take care. And we had some patients who felt guilty because they had sotatercept and others weren't able to enter the study. I think here we have really a lot of new challenges for both for us, but also for the patients who have a completely new perspective and who need to change their life and maybe in the other way around, or to define themselves new. And I hope that we will be able to address that maybe with the help of also of the companies, or because I think the healthcare situation concerning mental health is really limited, and so maybe we are able to empower the resources. Thank you very much.
Great. Thank you very much, Professor Olsen, for that. Dr. Rawlings, any reaction or question before you get started with your presentation?
No, not at this point. I'm looking forward to questions and comments and discussion at the end. Thank you.
Great. Okay, let me just get your presentation up now.
Thank you. Yes, I'm ready.
Ready.
Yeah, perfect. First of all, thank you very much for having me. I'm delighted to be here to talk about some of the research I've been doing in collaboration with PHA UK. PHA UK are the only dedicated charity in the UK for people with pulmonary hypertension. Next, please. Those are my disclosures. And next. So first of all, I just wanted to introduce myself. My name is Greg Rawlings. I have a master's degree in psychology. I have a PhD in neuroscience. I completed my doctoral training in clinical psychology in 2021. So I'm a clinical psychologist working in the NHS in the UK. I'm also a lecturer in clinical psychology at the University of Sheffield. My involvement in pulmonary hypertension is only involved in research, so I don't work clinically with this patient group. I work in the NHS with adults with a learning disability in my clinical role. But in my research role, I have collaborated with PHA UK and colleagues from Sheffield Teaching Hospitals on a range of research projects involving individuals with pulmonary hypertension as well as caregivers, and that's some of the work I'm going to be presenting today. Next. So I'm aware I only have 15 minutes, so I've decided to split my talk into 3 sections. So the first one is defining the problem, and I just want to kind of expand on some of the points that Professor Olsen's been discussing. Then I want to move on to what do we know about the problem before moving on to what are we doing about the problem. And this is a cyclic, so the idea is that it will then feed back into defining the problem and furthering our understanding. Next slide. So the first thing I just wanted to display was this graph here, which was published a few years ago by my own colleagues. So this is a meta-analysis. So this is a systematic review looking at prevalence of anxiety and depression in people with pulmonary hypertension. Anxiety and depression has probably been looked at the most as mental health conditions in pulmonary hypertension for different reasons. One reason might be is there's quite an overlap between symptoms of anxiety and depression and pulmonary hypertension. But this study looked at 24 studies, and it involved data from over 2,000 patients with pulmonary hypertension. And as you can see, the rates of anxiety and depression are very high. So on average, around 28% of people reported clinical levels of depression, and around 37% report clinical levels of anxiety. So very, very high rates, and as Dr. Olsen was saying, higher than what we'd expect to see in the general population, so higher than we'd expect to see people without pulmonary hypertension, for example. Next slide. We can go into more detail as well. So thinking about UK, for example. So in 2016, PHA UK conducted the biggest survey they've ever done of experiences of living with pulmonary hypertension. And as you can see, 563 people contribute to the survey. And these are just some pull-out findings I wanted to display. So 60% said PH had a major impact on their overall quality of life. And Professor Olsen has already mentioned the relationship between PH and reduced quality of life. 63% said financial worries had an impact on their lives. So some examples of some specific difficulties. Another thing I wanted to mention was 13% said PH had no impact on their general mental and emotional well-being. So the vast majority reported that PH had an impact on the mental and emotional well-being. And another finding I wanted to pull out was 24% said that PH treatment and management improved their general mental and emotional well-being a lot. In comparison, 53% said only a little, and 22% said no improvement. So that would suggest that there's certainly a need to think about the mental health and well-being of individuals with pulmonary hypertension. Next slide, please. So moving on to what do we know about the problem? So this table is taken from the Mao paper that I mentioned earlier, and this is looking at predictors or risk factors for anxiety and depression in people with pulmonary hypertension. Essentially what you're looking there is you're looking at the p-value, so that I don't think my pointer works, but anything below the 0.05, that would suggest that it's significant. So as you can see here, none of the demographic factors are a significant risk factor for depression and anxiety. So that would suggest that regardless of age, gender, sorry, my eyes are, age, gender, ethnicity, it would suggest that everyone could be at risk of anxiety and depression in pulmonary hypertension. The next thing is around diagnoses, and the final thing is around severity. And if you just click next, I'm hoping a red box will appear. If you just click next, yeah, perfect. So I just wanted to draw your attention to this, and this is looking at severity of pulmonary hypertension, and this is looked at through the World Health Organization functional class. And as you can see here, severity is measured by the WHO functional class is not a predictor of depression or anxiety. So it's not a risk factor, sorry, of depression and anxiety. So this led us to believe that available studies indicate that disease-specific factors alone are unable to fully account for the reported impact. And physiological measures of functioning tend to be non-significant risk factors for depression and anxiety. So that would suggest that there's something else at play. There's something else that we need to think about in terms of the higher risk for developing depression and anxiety in pulmonary hypertension. So next, please. So what we've been doing is we've been doing a range of studies looking at psychosocial factors to see whether they could help us to understand the high rates of anxiety and depression in this population, as well as the reduced quality of life. And this is just a few papers that we have completed and since published. The first one is looking at the relationship between anxiety and quality of life and depression and quality of life, recognizing that lower anxiety and depression would higher anxiety and depression would reduce health-related quality of life. But what we were able to find is things like external coping. So essentially coping skills were able to moderate that relationship. So it was able to weaken that relationship. And that's important because that could highlight a therapeutic target. If we can think about how people are coping with things like anxiety and depression and pulmonary hypertension, then maybe we can also help to improve the quality of life as well as manage anxiety and depression symptoms. The middle table is looking at things like self-compassion, so how compassionate someone is to themselves, to see whether that could help to predict anxiety and depression. And we found that, yes, it's a predictor, so self-compassion might be a therapeutic target. And then the third table was looking at predictors of anxiety and depression, looking at cognitions. So this is our thinking patterns and behaviors, so what we do. And what we found was that cognitions were more related to anxiety, whereas behaviors were more related to depression. And again, that can help us to think about therapeutic targets. So if we're working with a client who's presenting with anxiety, what we might want to focus on is cognitions, so thinking patterns. Whereas if we're working with someone who's experiencing depression, we may want to think more about the behavioral targets. So again, that's just a very brief overview of some of the work that we've been doing. And next, and now we're moving on to the third point. So what are we doing about the problem? So we recently done a systematic review of the evidence base looking at psychological interventions in pulmonary hypertension, targeting mental health difficulties. And what we found was there was 4 studies in total. One of them, Professor Olsen has already mentioned. And we found that all trials were associated with reduction in self-reported symptoms of depression and anxiety. So that suggests that there's some evidence to suggest psychological therapies are helpful for this patient group. However, what we also found was the evidence base is limited, and the evidence is only available from 77 people who've received a form of psychological therapy, and the data has been published. So again, this led us to term kind of with the title, is the evidence base disproportionate to the problem? So recognizing the high rates of anxiety and depression in this population. And actually, when we look at the trials, looking at psychological interventions, targeting anxiety and depression, it seems to be there's a mismatch between the two. Next slide, please. So one of the trials included in that systematic review is one of our studies, and this is where we developed and evaluated, using a pilot randomized controlled trial, and I'll explain what that means in a minute, a self-help intervention based on a type of therapy called cognitive behavioral therapy, or CBT, and this targeted anxiety in pulmonary hypertension. And our trial involved 77 adults with pulmonary hypertension. Next slide, please. So this is what it looked like. So we had 77 people who were randomized to either receive the self-help intervention, or they were randomized to receive or randomized to a waitlist condition. So this means they didn't receive any intervention in terms of our CBT self-help, but they did receive it at the end of the intervention. And the intervention itself is self-help. So this means that people completed at home at their own time in private. And there was 4 sessions or 4 weeks, which corresponded to 4 booklets. And each booklet, as you can see, had different contents and different exercises. And this was based on CBT. So this was a 4-week intervention. And what we did was, sorry, next slide. So what we did was we measured anxiety using a screening tool known as the GAD-7, the Generalized Anxiety Disorder 7 tool questionnaire. And we asked people to fill out this questionnaire before receiving the intervention, after the intervention, so this was 4 weeks after, and then 1 month after that, so 8 weeks after starting the intervention. And what this graph here shows is, as you can see, there's 2 lines. There's one in orange, and this is known as our control group. So this is our waitlist condition. So individuals randomized to that group didn't receive any intervention in terms of our intervention that we're offering. Whereas people in the blue line, these people were allocated, randomized to receive the intervention, so the CBT intervention. And as you can see, at baseline, they both scored within the moderate range of generalized anxiety disorder. Then at the post-intervention, so after the intervention, people in the CBT group reported mild symptoms, whereas those in the control group continued to report moderate symptoms. But also what's really important is that the GAD-7, the tool that we used, has a cutoff, and the cutoff is 8. So this means that if you score above the cutoff, it would recommend, or it might suggest that you may benefit from receiving additional support. And as you can see, people in the CBT group scored under that cutoff on the post-intervention. And then 1 month later, they continued to make improvements, and they continued to be under the cutoff. Recognizing the link or the overlap or the high correlation between anxiety and depression, we also measured depression. So if we click next, and we found something very similar. So we used the PHQ-9, the Patient Health Questionnaire, which is a validated tool for screening for depressive symptoms. And as you can see, we found a very similar results. So people in the CBT group reported a reduction into the mild and continued to stay below that clinical cutoff. So it's important to recognize that this was a pilot randomized control trial, which means that it's not a definitive randomized control trial. So that means that we needed more people in the trial to be to say with a high level of certainty that these results are an accurate reflection of what we found. Nevertheless, what it suggests is that it's preliminary evidence for its effectiveness. Next slide. So since we developed and tested the intervention and we've published the intervention, we've since made it available via PHA UK to all members, all service users of PHA UK free of charge. As of August, I think this year, over 220 people have requested the intervention. So when we look at kind of the prevalence of PH in the UK, this would represent around 2 to 3% of the population in the UK have requested these booklets. What we've also done is we've expanded on that idea, and we've developed booklets looking at depression in PH, and this is exactly the same idea: 4 weeks, 4 booklets, and we've since tested this in a randomized controlled trial, and we've analysed the results, and we've submitted for publication, and we're looking forward to sharing the results with the wider community when it's appropriate. So next slide. Thank you. So those were my 3 points. So defining the problem, what do we know about the problem? What are we doing about the problem? And based on the evidence, so based on our research, these are some ideas that I come up with that I think would be useful for future research. So the first is to continue to identify what factors are associated with anxiety and depression. We can also think about looking at other mental health difficulties in this population, recognizing that most of the evidence has been looking at anxiety and depression. Also think about how we can best identify people with PH at risk of mental health difficulties. I know Professor Olson was already mentioning this, so thinking about preventative strategies and also interventions when people do score above a cutoff, for example. Think about how depression and anxiety interacts with PH specifically, and also thinking about groups who are currently underrepresented within the evidence base. Also think about developing strategies to help people with depression and anxiety, and these can be standalone interventions as well as integrated care. And then finally, think about mental health difficulties in non-professional caregivers. So, for example, we done a study looking at rates of anxiety and depression in people with PH and their caregivers, and we found no significant differences in rates of anxiety and depression. So rates are high in non-professional caregivers, as are they high in this patient group. Next slide. I'd just like to thank my colleagues, and the next slide is my references, and that's the end of my presentation. Thank you very much for your time.
Thank you very much, Dr. Rawlings, and I like how you ended with ideas for already thinking about the next research projects. I want to first, before I ask some questions, give the floor back to Dr. Olson to see if she has any reactions or questions for Dr. Rawlings.
I do actually, but is Sophia going to join us, or are we?
Yeah, Sophia, good point. I was just thinking I didn't mention that. Sophia was supposed to join us. I guess she had technical issues.
Okay.
I haven't seen her come back now here in the room.
Okay, so
I guess it's not going to work.
In that case, I will. I have a lot of questions or comment, Greg. So, given that I think the waiting time for psychological intervention is often between like 6 months and a year, and we have seen that addressing it right at the beginning to prevent our patients from having like add-on psychological or mental problems. Have you also considered AI, or our colleagues are working on an app-based psychotherapy? Have you thought about this or implemented your intervention also via app, or do you have translations for that? So that it could be used internationally?
Yes, no, absolutely. So the way we tested the intervention was people in the UK who signed up to the intervention, they received a paper version of the booklets, whereas people outside the UK, they received an electronic version of the booklets. Due to sample size, we were unable to compare whether both were effective or whether one's more effective than the other. So that's something to consider. But no, absolutely, there's lots of online resources out there, and I think the kind of adaptation of some of our resources, thinking about anxiety and depression, could convert very well. One of the drawbacks, so we asked people's views on the booklets as well, and one of the drawbacks was there's some fantastic resources out there, things like videos and self-help, and we could signpost people to those resources. And if it was all on one app, click of the button, you could be directed to kind of a helpful resource. So we are looking at ideas of making an app and putting a lot of the resource. And PHE UK also have a great deal of resources as well. So if we could make it readily available, that would be fantastic. And I suppose one of the ideas is to reduce barriers to accessing support, whether that is due to resource or whether it may be due to other things like stigma of asking support.
So do you often face this? Because we had like we had not much dropouts, or we had like it wasn't difficult to recruit. But for example, Melanie in the comments says that it's often maybe a barrier or a lack of acceptance to accept that one needs psychological support. Did you face that, or did you recognize that? Because I think I think when talking to the patient, I think maybe 1/3 is stigmatized as having a mental disorder, like for years, rather than diagnosed having PH, and maybe there's a problem to accept that there's maybe both, or maybe it is not. It's the impact of PH which causes also.
Yeah, absolutely. And I think this is so in the booklets. The first week we were focusing on what we call psychoeducation. So it's around educating people around symptoms of anxiety, around symptoms of depression, think about how the two can overlap, normalizing a lot of these experiences, thinking about prevalence rates. I think that can be a really helpful way of normalizing and recognizing you're not the only one. What we also did was we created some fictional vignettes to kind of carry through the booklets, that people may be able to identify some of their own experiences, some of their own difficulties. So we've also recently reviewed the literature looking at what people said about living with pulmonary hypertension, and one of the things that came up was the rarity of the condition, and that can impact where you get resources, how people respond to you, even within medical settings. So and where Sophia is joined. So I'd love to hear from your perspective on these things. But yes, no, absolutely, really, really important points.
Hi, Sophia. Thanks for trying and getting in. No, we don't hear you. Wait. No.
Can you unmute her?
Yeah, no, she's not muted. Yeah, the mic should be on. Maybe it's a permissions thing or a browser thing.
It's too bad. It would be great to hear Sophia's thought, but maybe just until we maybe get that settled. Just one comment. I also refer to it as a whole, because if you want to treat PH, you have to take care of like alimentation, physical exercise, medication, and I think the mental health is just one thing. And I often refer to it as kind of coaching, because it's not like you have to need some expert tips. You also accept them if you need physiotherapy, for instance, and then sometimes you just need some flips to get over it. And I think it's kind of good. So can we hear Sophia so far?
No, I fear it might be a browser issue or some technical issue. Really a shame. Sorry about that. Normally it works pretty well and pretty easily.
Yeah, I think that Pisana and Eva just wrote in the comments that that in Italy and in Austria, psychotherapy was offered at the time of diagnosis, but it was not well accepted. That's really interesting, because I often have the feeling, or we are like addressing it kind of aggressively, and we rather have the problems that the access to psychotherapy is the problem, because we just mentioned it right from the beginning, like many things you have to cope with, like quite a normal thing that you have to address. And I think we have the access problem. But was it long ago, or was it recent, Pisana and Eva, maybe?
Meanwhile, also, Sophia shared a comment that diet is a big part of it. A lot of patients are getting very depressed when they have to rest, and perhaps eating then in that rest time as a symptom of the depression.
That's definitely a problem. If you can't move, you gain weight. It's like a vicious cycle. Or a vicious circle you're in. That's really also a good point. So, and the heart cath, So Sophia's just telling us that she was living with PH for 23 years and had over 20 heart caths. So that is a lot of downtime.
A lot to recover from.
Maybe that's also something we can try to address in medicine. I think there's a lot of movement towards ambulatory medicine to reduce downtime for the patients. Or if you have like a cervical access, you can just get up like a few minutes later after the cath. In contrast, if you have a cath through the groin, and maybe that also adds to quality of life to do everything as less invasive or with the least downtime and intervention in the normal life.
I agree.
Dr. Rawlings, I was wondering from a practical standpoint, if someone wanted to, like a patient association, as we have many listening, if they wanted to look into translating the booklet series, would they contact you or PHA UK to begin that conversation?
Yeah, absolutely. Contact PHA UK. So they're the ones who funded the trials, and they hold the copyright for the resources. But we've had other PHA organisations around the world contact us, ask whether they can start to adapt or translate. And absolutely, very, very keen to share resources. So please contact them.
Great, thanks so much for that. And Pisana adds, even a 6-minute walk test can be stressful. As kind of leading up to it, anxiety can build. And Melanie is saying that's true. And for some, they fear not doing well enough on the test. So a good conversation going in the comments. And Sophia also mentions here in the chat that some patients are intimidated by the gym because they walk in short of breath. Sophia has to take her oxygen tanks with her to the gym and still be active in some capacity, but getting approved for oxygen is yet another challenge. Really good point. And Sophia, I'll contact you after this and we'll find a time to re-record your part so that we can publish it alongside this webinar. But I think we've done well for today, and we've covered a lot, and we've had some really great presentations. Shame again that we couldn't hear from Sophia, but thanks again for trying and for being here. We'll reschedule it. Thank you also to Dr. Rawlings and Dr. Olson for sharing your research and for making sure that this is an issue that people don't just forget about or is swept under the rug, but even if there is some stigma attached to it, you're out there and researching it and trying to shine some light on it and understand it and kind of point out, that there's a problem and we need to do some interventions to try to stop that. So any other last words from our panelists tonight?
Nothing from me.
Like you first.
No, nothing from me other than thank you very much for inviting me.
I would maybe just also thank you and say that such comments such as Sophia just made, that you're afraid of the 6-minute walk, we also have to learn as physicians. I had to learn that also, that the anxiety to go to the appointment, will I perform well, will I do that well, is very important. So we are trying to do the outpatient clinic as nice as possible. And so Tadocet has taught us something, because people were coming every 3 weeks with the same patients, and that was really good, because it wasn't like a medical visit. It was like meeting friends, just doing the study stuff besides, and there were really groups and coffees and everything. And I think we have to work together, and we have to focus on that, and we need the patient input, or just to learn how we can improve also our performance with simple things, maybe just as meeting the same people for a coffee in the PH clinic.
Yeah, sometimes it's that simple, and that sounds like a really nice space you've created there, and one that most people would love to take part in. And Sophia says yes, or a pulmonary rehab clinic could be a great approach to getting patients interested in how to live a healthier life. So I'm taking that opportunity from there at the clinic. Yeah, great point, Sophia. So no, thank you all for joining, and thanks again to our panelists for your excellent presentations. And this recording and the slides will be up on the knowledge sharing platform of the Alliance for PH in just a few days. So check for it there. And our next webinar will be in November, and it'll be our first one in Spanish. So we're very excited for that, and stay tuned for more details on that. Thanks, everyone, and have a good evening.
Thank you.